So, hi, I'm Abby Phelps, and this is my fifth video, and I will be going over obstructive shock. Obstructive shock. So, when your patient has obstructive shock, something is obstructing or getting in the way of blood going in and out of your heart or through great vessels, especially major blood vessels connected to your heart. This obstruction can quickly lead to a huge drop in blood pressure and the amount of blood your heart is able to pump. So, specific signs and symptoms and physical findings that you would have with your patient that has obstructive shock, unusually fast breathing, hypotension, low blood pressure, tachycardia, fast heart rate, altered consciousness, excuse me, decreased urinary output, cool, clammy skin, subcutaneous emphysema, which is air under your skin, chest or abdominal pain. Imaging suspected obstructive shock. Chest radiograph findings may show cardiomegaly, excuse me, an enlarged heart, a water bottle shaped heart, pericardial calefactions, evidence of chest wall trauma. Echo cardiography remains the best primary modality for detection and assessment of cardiac tamponade. CT scanning can be useful in that it has a larger field of view, and CT can also provide better structural definition of the pericardium. You can do an MRI, but they're not typically used as much, but it can provide better structural definition of the pericardium and detect effusions. So here's a chest X-ray of obstructive shock. As you can see, it kind of is like the water bottle type shape that we talked about. So this anterior posterior view chest radiograph shows a massive bottle-shaped heart and conspicuous absence of pulmonary vascular congestion. So hemodynamics with this type of shock, you can typically have a low cardiac output, which shows the heart is not pumping effectively enough. A reduced stroke volume, which contributes to the low cardiac output. You can have an increased pulmonary capillary wedge pressure, which shows increased pressure in the left atrium, reflecting fluid backup in the lungs due to the failing left ventricle. SPR increases due to the low cardiac output by constricting blood vessels, and low systemic blood vessels is a result of the low cardiac output. Medications for obstructive shock. So, popular medications, vasopressors, which are first in line choices to increase your patient's blood pressure when shock persists. Inotropes, they help increase the contractility of the heart and improve blood flow to the peripheral tissues. Anticoagulant therapy for cases like pulmonary embolism. Heparin is usually a first line treatment, so the blood thinners are very popular. Cases like pulmonary embolisms, fluid resuscitation, this can include blood products um, if necessary, along with vasopressors to support circulation. ABG for obstructive shock, so lower normal pH can typically be seen a low PaO2 due to inadequate oxygenation due to the obstruction preventing the proper blood flow. Mildly elevated PaCO2 due to decreased cardiac output, which can impact your ventilation. Low bicarb is typically seen with this as well. So mechanical ventilation for obstructive shock, it is kind of the same with the other ones as well. They like to typically do a low tidal volume, around 6 to 8 mLs per kilo. They like um, one of the differences is an obstructive shock. They actually hear more about respiratory rate because they want to allow for an adequate expiratory time. PEEP, you typically want low, 5 centimeters of water, high inspiratory flow rate to facilitate rapid lung inflation and minimize airway pressure buildup. Prolonged expiratory time, like I said, by setting a high IDE ratio, which can sometimes be 1 to 4 or 1 to 6. Also, with this one, they have a little more of a preference with your ventilator mode. So pressure control ventilation might be preferred over volume control ventilation in some cases to limit peak airway pressures. Specific concerns and positive pressure ventilation. So concerns are tight organ dysfunction and this can happen due to insufficient blood perfusion. Neurological impairment, reduced blood flow can cause confusion, alter mental status, and even coma. Renal dysfunction, decreased urine output in your patient. Your patient can even have cardiac complications. The reduced cardiac output can lead to further myocardial damage. Pulmonary distress can cause respiratory distress, and hypoxia can occur in your patients. So, with positive pressure ventilation is generally used with caution due to its potential to worsen the situation by further increasing right ventricle afterload, which is already elevated due to this type of shock. Therefore, when you use positive pressure ventilation in obstructive shock, it is crucial to utilize low tidal volumes and minimal PEEP to minimize the detrimental effects on the right ventricle. So, like I was saying in some of my other videos, it is very popular for them to have those low tidal volumes, low PEEPs, just because it does affect the heart in like many different ways, as I've read through a lot of the different kinds of shocks. So summary, so physical exam findings, imaging with chest x-rays, hemodynamics and monitoring, medications, ABGs, mechanical vent settings, specific concerns, and positive pressure ventilation. So we went all through those. So obstructive shock is a life-threatening condition that occurs when blood flow is blocked in the heart of major blood vessels. And this prevents the body from getting enough nutrients and oxygen. So here are my sources for my entire PowerPoint. All right.